rotated. That's going to introduce some motion into the system. We want to put her in as neutral a position as possible. I'm going to take my hand, the little space between my thenar and hypothenar eminence, I'm going to put the spinous process. And I'm going to evaluate T1 through 4 with the PA central. And to evaluate T1, 2 extension, this is what I'm going to do. The PA central, which is going to close the facets and extend the spine. I'm going to be on the spinous of 2. So how do I find that? I come down the spine, and I extend, and I find promenons, and I come down from there, 1, 2. And I get on 2. And I do a PA perpendicular to the table. And it's a spring. It's not a thrust. It's an impulse. And I just, impulse, you can do it twice. You can do it once if you want, or I usually go in 1, 2. And I'm thinking about same old as before, quantity, quality, and feel, and reactivity. As I move 2 under 1, down towards the table. And then I go to 3 under 2, and 4 under 3, and 5 under 4. And that gives me an assessment of upper thoracic extension. And that would be very useful for someone who has a rounding in their upper thoracic area, the beginning of what we call a dowager's hump, right? Now some of that dowager's hump is postural, some of it is postmenopausal, where because of osteoporosis, there's some wedging of the vertebra. I recently came across an article that said that forward head posture actually is the catalyst for the osteoporotic deformity. It doesn't cause osteoporosis, that's metabolic, but it's the catalyst that causes the deformity, is the forward positioning of the head, stressing that area metabolically. So, this could be very useful in someone who's premenopausal, who's developing that postural hump early on. So 2 under 1, 3 under 2, 4 under 3, 5 under 4. Then when I get down to 5 to 12, I'm going to shift, come down here from below, and because the thoracic spinous processes angulate down, the further down I go, the more they angulate inferiorly. In the upper segments, they come straight back, they project straight posterior. As you get lower down, below 4, they start to angulate down, especially the lower segments. So what I do to be in line with the joint is I drive the spinous process up towards the sternal angle, the manubriosternal junction, right there. That seems to give me a good line of drive for the thoracic facets. So I get on, I want to do 5 through 12, so I get on 6 under 5, and I drive it towards the table and up towards the sternal angle. 7 under 6, 8 under 7, 9 under 8, 10, 11, 12, 1. Trying to feel for restriction. Quantity, quality, end feel, reactivity. Now the end feel we're going to use here, we're going to really simplify things. We had the Syriacs, right? We had the 5 normal and 5 abnormal, 5 normal, 2 abnormal, right? Is that it? Count them when we had 3. We had soft, firm, and hard, pluses and minuses. You can use those if you want, but I would suggest that you just basically say normal, stiff, or loose. It works for me. Normal, spring, give, stiff, seems restricted, or it just seems too loose. There's too much motion there. Loose, hyper, stiff, hypo. That's fine. If you want to give it a grade, you can, 0 through 6. So don't get so hung up with the names here of the end feel, like in the extremities. Just start to feel for where it's restricted. Locate the restricted segment. And of those restricted segments, try to find the area of greatest restriction. That's where you're going to start your work. Now, are you wondering why to assess 1, 2, I'm on 2? To assess 5, 6, I'm on 6? How come I'm not on 5 to assess 5, 6? How come I'm not on 1 to assess 1, 2?
So you want it's for extension.
Yeah.
So if you move 6 on 5, then putting 5 into extension.
Yeah. Okay. You're right. Do you know why? It goes back to the biomechanics lecture. We're going to review that again on Tuesday. So give me your finger for a second, right? So let's take T4-5 extension. So to extend at 4-5, I rotate 4 posteriorly around the x-axis. 4 glides posteriorly on 5 along the z-axis. What does 5 do under 4? It glides anteriorly along z. So when I'm on 5 going P to A, I'm inducing extension at 4, 5. If I'm at 2, moving 2 from P to A, I'm inducing 1, 2 extension because it's a linear movement. Now if I was on the spinous process and I overturned it, I rotated it, that would be different. This would be 1, 2 extension. I'm driving it down. This would be 2, 3 extension. When I do a linear movement, I'm along the z-axis. So if it's straight linear, I know I'm angulating it a little bit because of the alignment of the SP, but it's still linear. Then I'm moving the bottom under the top. Okay, remember that? We'll review that again on Tuesday. We'll work it out. All right, so that's the PA central. The next one is the transverse pressure. So I'm going to start at 1. This is my passive or dummy thumb, just for padding. My active thumb over it. And I'm going to move 1 to the left. This is transverse pressure. Now, we'll go through this again next week, but motion of the spine is always determined by the body, not the spinous process. So if I move the spinous process of 1 to the left, I'm moving the body of 1 to the right. It's considered T1-2 rotation right. Even though the motion is occurring via the spinous process, it's described by what the vertebral body does. So I'm moving T1 to the left, that's 1, 2 rotation left. 2, 3, 3, 4, 4, 5. Just gentle transverse pressure, rotating the vertebra. You can do that. Some people like to come in with one thumb on 1, and they stabilize on 2 on the other side and move it like that. You get a little more counter, some more stability. You can do that. The thoracic spine is pretty stable, and you get a sense of very light force where there's restriction. Applying the pressure on the side of the spinous process, standing on the right to her left. So in order to assess rotation left, I have to stand on the right. And I can use this as a mobilization, but I have a sense that we get more done with the physiologic than with the accessory. It's definitely an option. If the physiologic for some reason doesn't work, we can come in here and we can do this as a way of mobilizing the spine. But it's nice as another way of assessing. It's nice to have more than one way to assess. We have our PAIVM, we have our pivot. But I'm not going to do more than those two. There are others we can do, but I think these work really well for extension and rotation. For side bending and for flexion, we have other ways to do it.